Welcome to the series Metabolic Acidosis and Chronic Kidney Disease, Evolving Management Strategies. Today's session is the first of 3 weekly modules and is entitled Prevalence and Risk Factors of Metabolic Acidosis and Chronic Kidney Disease. My name is Dr. James Matera, and I'll be the moderator for today's program. I am the Senior Vice President for Medical Affairs and Chief Medical Officer of Central State Medical Center in Freehold, New Jersey, and a practicing nephrologist. I'm joined by Dr. Vandana Mathur, who's the president of Mathur Consulting and on staff at the Clinic by the Bay in San Francisco, California. These are our disclosures for today. Today's session is approved for 0.5 CME, CNE, CPA, and AAPA credits, and this is provided by the North American Center for Continuing Medical Education, LLC, and HMP Company. We are also supported today by an educational grant from Tresita Incorporated. The learning objective for today's module is to describe the consequences of metabolic acidosis in chronic kidney disease and considerations for treatment. So what is the prevalence of chronic kidney disease today? We know that it's a national issue that's becoming very prominent, and upwards of 15% of adults in the United States are known to have chronic kidney disease. And that equates to about 37 million individuals. There are a lot of chronic comorbid conditions that we see in patients with chronic kidney disease, including hypertension, very prevalent at 86%, type 2 diabetes or type 1 diabetes at almost half of the population of CKD, and still the #1 cause for end-stage renal disease in the United States. And certainly our cardiovascular disease, which is the primary component from which chronic kidney disease patients experience most of their morbidity and mortality. That being said, though, there are a lot of issues that fall into why chronic kidney disease patients have these cardiovascular risks. And that's part of what we'll talk about in the next few modules. So how about a kidney failure risk equation? We know that there are several variables that will independently predict the risk of a patient progressing to end-stage kidney disease. One of the most important things and discussions I know Dr. Mathur and I have with our patients is, what does chronic kidney disease mean to me, and how will it affect me down the road? And there are multiple factors that impact this. Certainly we know that older age, male gender, a lower estimated GFR at the time they start to see the nephrologist, a higher albumin to creatinine ratio or proteinuria is a huge risk factor in most diseases, a lower serum bicarbonate, and we're going to focus some time looking at that today, lower serum calcium levels, a higher phosphate level, and there are various reasons why a patient with chronic kidney disease will start to get hyperphosphatemia, and it all plays into their cardiovascular risk. And even those who do have a higher albumin can sometimes have a risk factor for this progression. And those are the things we want to focus on.
Yeah, Dr. Matera, this being able to go through the risk factors with CKD progression with patients, I find it to be so helpful to be able to walk them through their data on the KFRE equation and show them all of the things that are contributing to their personal risk. I think it's helpful for them to understand, why we're prescribing certain treatments and how to interpret their own lab results. I think, you're very involved in patient engagement, and I think, that kind of thing is very helpful in reviewing patients' labs with them to speak with them about their personal risk.
Yeah, I think that's important because we need to have our patients empowered to make some pretty critical decisions about their lifestyle. We know that our patients have all these risk factors, and we want to try to modify them as much as possible. So looking at this slide, we can do that by impacting their lifestyle. Obesity and smoking are 2 very big ones that we look at. Certainly modifying their hypertension. I know there's been a lot of argument the last few years as to what the appropriate numbers are, and we have data, from JNC8, the SPRINT trials, and other trials since that time that help us better define that. Hyperlipidemia has become an important factor. Certainly control of diabetes, we know, is very important, and keeping those A1Cs under control. And more importantly now, and I'd like your input on, it's not only how we do this, but what we use. Certain medications we now know may be more beneficial when we're targeting diabetes. You have any thoughts on that over the last few years, the Credence trial, things like that?
Yeah, absolutely. I think we have so many choices now how to manage glycemic control. And with the advent of the SGLT2 inhibitors, I really think of these more as not diabetic drugs, but really more drugs for reducing overall cardiovascular risk because their glycemic effect is relatively small compared to other agents. So I think it's helpful to take the patient's entire cardiovascular risk into consideration in determining whether one of these drugs would be, useful as an adjunct to their anti-diabetic other medications and our overall strategy to reduce their cardiovascular risk. And I think I would also say that, with hypertension, even when the targets were higher, personally, I find it quite hard to get patients to target, and a lot of patients are running around, or not at target. And if we're trying to target 120 systolic blood pressure, it just makes it all the more difficult, to actually achieve that in real life. And so I think we have to redouble our efforts at sodium restriction, diuretic use, and, all the other things we have in our toolkit to address hypertension.
Yeah, we have the tools, we have the desire, but sometimes we don't get the input or the cooperation. And you've seen studies as well where a vast majority of our patients may not be controlled to certain targets, and we really have to do better on that. The other two risk factors are proteinuria, which we all know is very damaging to the kidneys. And again, choice of medications is important there. And a little bit of what we'll talk about today, metabolic acidosis. That's becoming a much more important factor. We know our patients have metabolic acidosis, but we're starting to understand the impact of that. And that's what we'll focus on a little bit through the next few modules. So I put up a diagram here from seminars in nephrology, which is the effect of the risk factor modification on progression. Now, we all know the upper part of the graph here, the blue lines, is what we would love to see, where we don't have any progression of chronic kidney disease, or in fact, stabilization, which is the flat line, or some increasing glomerular filtration rate. We don't get to see that too often. What we mostly see is the lower figures, the red lines, a progressive decline or a nonlinear progressive decline over time. And there's been some various studies looking at what that time would be, but by and large, we see a decline in the GFRs for our patients that does increase their risk as time goes on and they progress through stages. Our goal for therapy should be prevention of this progression, because we really can't achieve those upper blue lines. We would love to. But the more we can prevent progression to end-stage renal disease, we can help promote some accurate predictions and more effectively reduce individual risks.
Here is kind of a stepwise reduction in kidney function where, patients are relatively stable, but then they have some acute event happen to them and they develop AKI and they never really fully recover. And they have this, big stepwise drop in their GFR, and then they might remain a little bit stable at that point. So I think we see all different patterns and, our ability to prevent hospitalization and AKI, I think, is very much, part of this mix of risk reduction.
Absolutely. And I think we're just starting to see in the age we live in now, how the effects of COVID-19 will be on some of our chronic kidney disease patients. Right. We know acute kidney injury has been a big tenet of COVID-19. So I'm looking into the future to try to see how that's going to affect progression. Okay, so the KDIGO recommendations for modifying risk factors are pretty general. We've spoken a little bit about those. Certainly blood pressure control, and not only how you get to the goals or targets, but what you use to get there. Avoidance of a high protein intake in the diet. Glycemic control is more important than we thought. Lowering the sodium intake is of primary importance, especially in our patients who have comorbid conditions like congestive heart failure. And then treatment of metabolic acidosis have been getting a lot of attention recently. So we can also indirectly reduce cardiovascular risk by encouraging our patients to have regular physical activity. People are walking around with their Fitbits and their Apple Watches now, counting their steps. A lot of the gyms are closed. I hear that from my patients all the time now. So we have to get more inventive, and just walking is a good regular physical activity. Maintaining a healthy weight, and certainly avoiding things like smoking. Those are all good things that we can do to help modify these risk factors. So Dr. Mather, I'm going to turn over the remainder of this module to you, and I'll comment along the way.
Great, thank you. So we know that various kinds of acid-base disorders are common in patients with chronic kidney disease, particularly metabolic acidosis. And because the maintenance of pH is so important for the cellular milieu and cellular functioning, chronic states of acidosis contribute to a number of adverse sequelae. The evidence suggests now that there's benefit from treating chronic metabolic acidosis in these CKD patients, and our mainstay of therapy has been alkalinization with sodium bicarbonate. The acidosis affects primarily the musculoskeletal system and as well as the kidneys. In the musculoskeletal system, we have muscle wasting, bone disease, hypoalbuminemia, inflammation, and also progression of chronic kidney disease. And all of these things contribute to the increased mortality that's observed in patients who have metabolic acidosis compared to those who do not and have equivalent levels of chronic kidney disease. Despite the fact that there are these numerous, musculoskeletal and kidney complications related to metabolic acidosis, today, when we look at the published studies, we find that metabolic acidosis is both underdiagnosed and undertreated. In this particular study shown here, it was a large epidemiology study with about 86,000 patients with CKD and chronic metabolic acidosis, very rigorously defined by their GFR and their serum bicarbonate values from this database. 21% of those who had metabolic acidosis had an actual diagnostic code. So we're not coding very effectively for metabolic acidosis. Not surprisingly, patients with an older age had a older age and higher eGFR was associated with a lower likelihood of diagnosis. Maybe these patients, other diagnoses are just kind of bundled together. And then visiting a nephrologist, having health insurance, and having comorbid conditions were actually associated with a greater likelihood of diagnosis. So it may be that non-nephrologists are less frequently coding, for metabolic acidosis. Now, interestingly as well, among patients who clearly had metabolic acidosis based on their bicarbonate levels, and had CKD, only 15% received oral alkali treatment. And of those who received it, only 36% of them were still taking it after 2 years. And the discontinuation rates with the alkali were very high in the early parts of the treatment within the first 180 days of use. So I think this highlights, to a significant extent, I'd be interested in your thoughts, as to, the dilemma with using alkali-based treatments in these patients. It seems like one of the problems is maybe lack of diagnosis, or certainly lack of coding for the diagnosis, and the other is, an unwillingness to treat.
Yeah, I think those are two great points you brought up. Nothing gives shivers to my medical students more than when I bring up acid-base disorders. They don't like them. The only thing they remember is Winter's formula. But I think this is a great point because it really highlights two key issues. Number one is I think it's being underdiagnosed, and that may be because the nephrologist may think about it a little bit more. But also, once it is diagnosed, it's undertreated, and of those that are treated, the continuation of therapy is very poor. So that really screams out to us needing to be more vigilant in diagnosis, and certainly trying to have better supplementations or better treatment protocols with which to treat it and improve those discontinuation rates.
Yeah, I think patients just don't love taking sodium bicarbonate. It's tough to get them to take more than a little bit, and even that is not very well tolerated oftentimes.
Yes.
So let's reflect a little bit now on who is it that develops metabolic acidosis, and why do they develop metabolic acidosis? By the time we make the clinical diagnosis of metabolic acidosis, typically we find that patients have GFRs that are fairly low, typically below 40 and often less than 20 to 25. It's important to recognize that the metabolic acidosis is caused by tubular dysfunction, which can occur at higher levels of eGFR as well as lower levels of eGFR. And that's why we see somewhat of a range of when the bicarbonate starts to fall. If we look at big databases like NHANES and the CRIC study, we see that the prevalence of metabolic acidosis goes up with progressive CKD, starting at stage 3A to 4, 11%, 21%, 36%. And in the CRIC study, you know, kind of similar numbers. And this is again defined by serum bicarbonate. And I think one of the important, you know, maybe more nuanced points to keep in mind is by the time the bicarbonate falls, this metabolic acidosis in the CKD patient has been going on for a while. And because as we'll talk about, you know, various buffer systems are kicking in to help maintain this bicarbonate in the face of ongoing acid retention. And in CKD patients, this is one of the, you know, one of the few things on the differential diagnosis for metabolic acidosis that can give you both a non-anion gap as well as a high anion gap acidosis. And sometimes we see both in the same patient at different points in time. So when, you know, when people have normal kidney function, you know, they are able to deal with an acid load. Every day we consume an acid diet. We generate acid through metabolism. And this experiment, which is, you know, very nicely done, shows that, you know, if you administer acid, you know, as in the form of NH4Cl to experimental subjects, they can and will increase their ammonia excretion and help get rid of that acid. And as we can see, the other mechanism that the kidney uses to excrete acid, titratable acid, is really not something that can be scaled very effectively. So really, in the face of acidosis or acid retention, you know, what the kidney is doing is generating, is creating, you know, more ammonia and then excreting it in order to get rid of acid, and it's doing that by causing 2 bicarbonates to be generated for every ammonia that is produced. Okay. Now, if we look at patients with chronic kidney disease, you know, these patients have a very different pattern. So this is a similar experiment where we're looking in the top panel here at the TCO2 or the bicarbonate, and the lower panel we're looking at the ammonium concentration in urine. And in the healthy patients, we see that, you know, they are able to, on the bottom panel, increase their ammonia excretion within a day or two as more ammonia is generated, whereas patients who have chronic kidney disease have an essentially flat line ammonia excretion, so they are just not able to increase their ammoniogenesis. And thus they are retaining acid, and we see clinically on the top panel, their serum bicarbonate or TCO2 level declines in the face of acid loading.
Yeah, and I think the fact that you brought out the tubulointerstitial process, I think that's very important here, and we have to understand the importance of the interstitium and the tubulointerstitial process on this. And just that inability to respond to the acid load is what gets our chronic kidney disease patients into trouble.
Yeah, they're much more vulnerable to dietary swings in acid load and just the chronic retention of acid over time. So let's take a look at some of the adverse sequelae of metabolic acidosis and you know, why these occur. So in the face of acidemia, we have a number of compensatory mechanisms that kick in. These are initially adaptive, but ultimately turn maladaptive. So one of the things that happens is acidosis directly causes bone to become demineralized, and it's a direct physicochemical effect of the low pH. And osteoclast function is also enhanced in the face of acidosis. And the net effect here is you're releasing from the bone skeleton carbonate, sodium, calcium, and these serve in the short term to buffer, you know, this acid retention. But in the long term, of course, lead to bone demineralization. On the other side, on the left side, muscles, which are obviously a large, you know, organ system, are also contributing in aiding the prevention of lowering of serum pH by catabolizing, releasing amino acids, which include glutamine that can be used for renal ammonogenesis. But in the process of this muscle catabolism, we now have, muscle wasting and development of sarcopenia that happens in these patients. Now, interestingly, within the kidneys, if we think about these CKD kidneys with a diminished number of functioning nephrons, they are now trying to deal with this daily acid load and cumulative retention of acid by just trying to work overtime and get rid of acid. And the way this happens is the remaining nephrons, under the influence of activation of endothelin-1 and the renin-angiotensin system, are able to excrete more acid per nephron by activating a number of transport mechanisms, sodium H transporters and other transporters to get rid of acid. But at the expense of these remaining nephrons working overtime and at the expense of having these profibrotic pathways activated. And ultimately, it's this complement activation related to acidosis, these profibrotic pathways that then lead to further inflammation and fibrosis within the kidneys, causing then, further GFR decline, further loss of tubules, and further inability to excrete acid. So it becomes sort of a vicious, negative cycle.
Yeah, I think when you use the term maladaptive, that's an excellent term. We could see how complex this system can be and how many checks and balances are in there. And once those checks and balances are off, we start to deal with all the sequelae. Yeah,
it's a common theme in CKD, adapt while you can, and then you eventually lose the ability to adapt. Okay. So, this then leads us to, well, what really would be our treatment goals in trying to treat metabolic acidosis? I think for most nephrologists, one of our top goals in caring for these patients is to do whatever we can to reduce the risk that their CKD will progress. And then we're also interested in the whole patient, and sort of their overall being and functioning. And to that extent, what we can do to help improve their skeletal muscle, to improve their bone health, so that they have less debility as they progress through CKD. That's an important, physician goal, but I think also a very important patient goal. And then, of course, with the treatment of metabolic acidosis, we may have a secondary goal of trying to help keep the systemic potassium in check if that patient is hyperkalemic.
Yep, all excellent points. And I think in the next couple of modules, we'll be talking a little bit more about how we can effectively manage some of these strategies. But just so important to know that we can be more proactive with our patients early on to try to lessen their risk factors. All too often, and I know I've been in nephrology for 30 years, we can see our patients go through a multitude of things, and we didn't understand all this recently. So most of our patients kind of got beyond the scope of being able to prevent any of these things. And I really think that the focus has to be on prevention of a lot of these things.
Yep, agree.
Okay, I'd like to thank you all for joining us on our program today. If you have any questions, please submit them in the Submit a Question tab, which is located on the right-hand navigation bar, and one of our expert faculty will respond to your query. To receive your CE credit for today's program, please complete the evaluation, also located on the right-hand navigation bar. You'll then be able to download your certificate and print it. Please join us next week when we launch Module 2 of the series, Diagnosis and Management of Metabolic Acidosis and CKD. Once again, thank you for participating in this program.